Hello, I'm Dr. Manish Singhal, medical oncologist at Apollo Hospitals, Noida and Delhi. We are presenting the Esmo update meeting. Esmo is European Society of Medical Oncology meeting, which was held this year in October 2023. This is a meeting which is attended by global experts across the world, and it provides all the up-to-date information about various cancers. And we are happy to announce that this meeting was held under the aegis of Apollo Hospital and was held on 4th of November at Radisson Blu, Sector 18, Noida. And we were able to invite faculty across Delhi NCR and all other cancer experts, which shared their views on these updates, and was attended by a lot of students. And I'm sure that these updates includes not only about breast cancer, lung cancer, GI cancers, gastrointestinal cancers, GU cancers, but also supportive care and sarcomas. It's so very important to keep up to date to provide the best possible care to our cancer patients. And I hope that you like these updates, and we will keep introducing more updates like this in the future. Thank you.
Good afternoon, everyone. First of all, I would like to thank the chairpersons, and I would also like to thank Dr. Manish Singhal for giving me this opportunity. So the study which we are going to discuss here we are going to discuss this very briefly. This is actually a practice-changing study which is now coming to, which was discussed in Esmo updates. Now, talking about this study, this is a Gcig Interlace study. This actually discusses neoadjuvant chemotherapy in CA cervix followed by CTRT versus CTRT, which has been the practice till now in the locally advanced CA cervix. So very briefly, if we just talk about the randomization, total 500 patients were taken, randomized into two groups, 250 patients in each group, and the key eligibility criteria has been mentioned here. There were histologically confirmed cases of locally advanced stage and adenosquamous and squamous CA cervix. And then the induction chemotherapy arm was weekly paclitaxel for 6 cycles followed by CTRT, and the other arm was directly we take the patient up for the CTRT, right? And after that they were stratified according to the stage nodal status. The primary endpoints were PFS and OS, and the secondary endpoints were the adverse events, the patterns of relapse, quality of life, adverse effects, etc. Now, if we talk about the characteristics at baseline, the characteristics at baseline were comparable more or less between the two arms. The number of patients were almost equivalent of all the stages as well as the histology. Further, if we talk about how they adhered to the treatment schedule, the protocol, if you will see, then directly if you talk about the first group, that was the induction chemotherapy group, around 84% of the patients completed the 6 weekly cycles, 92% completed at least 5 cycles. Among these, now expected hematological adverse events and non-hematological adverse events were there. Total among the 250 patients, 29 patients had the adverse events, among which the non-hematological ones were more prominent. And now after this, these patients were put into the CTRT arm. Now if we talk about compare the adherence to concurrent chemoradiation between the two arms, then we'll see that as expected, the adherence to the chemotherapy was better in the CTRT alone arm, where around 79% of the patients completed the 5 weekly cycles and around 90% completed 4 cycles. Whereas in the induction chemotherapy arm, only 68% were able to complete the 5 weekly cycles and 85% completed the 4 cycles. Same with adherence to radiation. Now, a major secondary endpoint was the adverse events. If we talk about the overall adverse events, again, around 90% of the patients developed some adverse event in the CTRT arm, and around 99%, almost all the patients in the induction chemotherapy arm developed the adverse events. There was a considerably higher percentage of hematological adverse events in the induction chemotherapy arm, which again is more or less expected. Now, the main endpoint was the PFS and the OS. If you talk about the progression-free survival, then in 5-year PFS, there was an advantage of almost 9% was substantially more in the CTRT arm than in the induction chemotherapy arm. So if we see, to conclude, the induction chemotherapy arm led to a 9% improvement in PFS and an 8% improvement in OS at 5 years. Along with that, there was definitely slightly more hematological toxicities in the induction chemotherapy arm. The adherence, but more or less, was similar between the two arms. So, and yeah, as we had seen previously, the rates of this, local relapses and distant relapses were more in the CTRT arm compared to the induction arm. So I think this is a practice-changing trial, which we should be able to apply more or less more to more of our patients in the coming time. Thank you.